So the first presenter for this morning will be Ms. Alyssa Mercade, or Mercadet, but pronounced in French, Mercade. And the first presentation is Intraracial Disaggregation, Reveals Associations Between Nativity and Overall Survival in Women with Endometrial Cancer. So Alyssa, on to you. Thank you very much.
I'm Alyssa Mercado. I'm one of the second-year gynecologic oncology fellows here at University of Miami, and I'm going to discuss some research that we recently published. So just to give some background, every year around 65,000 women are diagnosed with endometrial cancer in the U.S., and there's over 400,000 cases diagnosed worldwide. And so despite us having all of these different advances in treatment, endometrial cancer has had the greatest increase in cancer-related mortality among women. Also with endometrial cancer, it's associated with one of the largest survival disparities, with Black women having a higher rate of mortality than women with all the different histologic subtypes. So potential factors that may be leading to these disparities that have been proposed are advanced stage at the time of diagnosis, Black women being diagnosed with more aggressive histologies, Black women having limited access to care compared to other racial and ethnic groups. And then there's been research that has showed that for Black women, there is more departure from guideline concordant treatment, which may play a role in worse outcomes. So just some other things that we discussed in our paper that we thought would play a role in kind of setting the scene for our research. So due to forced migration from West Africa, there's been a lot of flux between Africa and the North America and islands, leading to very diverse genetic composition of the Black population. Specifically in the U.S., the Black population is comprised of both those born in the U.S. and those born in other countries that have immigrated to the U.S. And so we discussed that, this necessitates a more comprehensive and granular approach in making risk estimations and not just putting Black women in one bucket. There's more stratification that needs to happen. And then also in 2019, it was identified that 56% of all Black immigrants in the US were born in Caribbean countries, with the most women coming from Jamaica and Haiti. And the ancestry from those islands are also distinct and very heavily influenced by each island's geopolitical history. So we have limited knowledge on how specific countries of birth are associated with endometrial cancer outcomes. We think that it's possible that country of birth may play a role in the pathogenesis, as this can subject a woman to different socio-environmental exposures, socio-cultural practices, and molecular epigenetic changes. There's also data that we've done here at the University of Miami that indicates that Caribbean-born Black women collectively may have improved overall survival when compared to US-born Black women. But we've never disaggregated these women by nativity to assess variation in outcomes. So our research objective was to determine if country of birth influences endometrial cancer overall survival in disaggregated subpopulations of Black women. We use the Florida Cancer Data System with women that were diagnosed from 1981 to 2017. We abstracted demographic and clinical information and then included women that self-identified as Black and born in the US, Jamaica, or Haiti. And then we performed our statistical analyses. So this is our flow chart, just kind of showing our inclusion and exclusion criteria. We included 3,817 women after applying this criteria. This, I guess, table is a little bit smaller than I expected. But this is just kind of going over the demographic background, and some of the highlights are that, compared to U.S.-born Black women, Jamaican-born and Haitian-born women had more high-grade histologies, as evidenced here with the serous and carcinosarcoma, more advanced stage disease, with higher percentages for distant disease, and then had a greater proportion of uninsured and Medicaid insured women. Also, compared to US-born women, Jamaican-born and Haitian-born women had a higher proportion of women who received chemotherapy for treatment, and a lower proportion of women that underwent hysterectomy for treatment. So the next few slides will kind of go over the results that we had for overall survival. This first figure is including all of the histologies. And then when looking at all of the histologies together, women born in Haiti had a worse overall survival compared to women born in the US and Jamaica. So the median overall survival for Haitian women was 35 compared to 43 for US-born women and 58 for Jamaican-born women. There was no statistically significant difference in overall survival for women that had endometrioid carcinoma based on country of birth. And then another finding that we thought was very interesting was that among women with serous carcinoma, Haitian-born women had pretty significantly worse median overall survival compared to US-born and Jamaican-born women, with Haitian-born women having a median overall survival of 18.5 months compared to the US at 29.9 and Jamaica at 41.1. And then there also was no difference found with women that had carcinosarcoma. So for all histologies, like I discussed, Haitian-born women had worse overall survival compared to the U.S.-born cohort with a hazard ratio of 1.2. And then Haitian-born women with serous endometrial cancer experienced lower overall survival with a hazard ratio of 1.5. And then after controlling for confounders in our multivariable analysis, the Haitian-born women, their country of birth remained a significant predictor of overall survival when compared to US-born women with a hazard ratio of 1.5. And compared to Jamaican-born women with a hazard ratio of 1.7. So this is one of the first studies exploring the differences in endometrial cancer outcomes based on country of birth in Black women. We have a high number of Caribbean immigrants in Florida, and so we are uniquely positioned to be able to disaggregate some of the Black population and by country of birth and evaluate if this is associated with survival outcomes for Black women. And the most important thing that I think we found that warrants more research is that in this cohort we found that Haitian-born women experienced worse overall survival when looking at both all of the histologies together and then also looking only at serous carcinoma. And so proposed factors for the disparities that we found in our study, specifically for Haitian women, there has been described an effect of triple minority status, where Haitian-born Black women in the US have to overcome being Black, have to overcome being a foreigner, and then also being Haitian Creole speaking in a place where that is not the majority language. Also, the delay in care may contribute to differences in the stage of presentation and outcomes for the timing of immigration to the US. And so there also has been a lot of research that has identified that cancer patients that are coming from other countries may have delays in care, and obviously that's going to lead to them presenting at a more advanced stage than someone that's already here in the U.S. We also have done research here in Dr. George's lab. One of her PhD students has identified that increasing African ancestry is associated with serous carcinoma. And just kind of in my literature review, I identified that Haitian-born women have been described to have an increased African or percentage of African ancestry just based on the migration patterns, and this may be why we see that these women have more serous carcinoma and also have worse overall survival. And then something that we don't necessarily have a lot of information on but would be interesting to look into more is the interplay between these social factors and then things that we're talking about more often now, the genetic and molecular characteristics of these women. Just some limitations, so we're limited by the variables that are in the cancer registry. It would be very nice to know, like the primary language, the interval of time between diagnosis and treatment, and causes of death. We didn't have like cancer-related mortality, we only had all-cause mortality. So that would be information that would be helpful to have in future studies. And then the data was collected over a very large period of time, 35 years, so that allows for some temporal bias and changes of how endometrial cancer is treated, changes in how the population is made up in like different environmental factors. And then we had low counts from other countries. So we only had people born in the US, Jamaica, or Haiti in our study. But obviously women in America that are Black have a lot more than just Jamaican, Haitian, or US background. And so that would warrant further stratification to look more into this disparity. And so in conclusion, our study calls for attention to the notion that Black women with endometrial cancer are not all the same, and we need to develop a stronger body of work to focus on these healthcare disparities. And then although the extent of the differences haven't been established, there may be subgroups of women with endometrial cancer that require modifications to treatment, increased surveillance based on their country of birth. And so future research combining clinical, genetic, and molecular data would definitely be helpful in trying to further stratify and help women that are particularly vulnerable with endometrial cancer. And that's all.
Our next presenter is, again, Dr. Sophia George, who will present on current trends in genetic testing.
I think we got a primer already of all the genes, but I made this a little bit slower and to like take some time to describe the difference between germline and somatic testing, as I was asked, and then I think I have like one example of a case, not my case, obviously, but from someone else. Okay. Oh. So to go over this again, germline, for us, we think about blood and saliva, sometimes even a skin biopsy. And for somatic, we're thinking about the tumor specifically, okay? So what's the difference? So germline mutations occur in a parent's reproductive cells, so the egg or the sperm, and these mutations change the genetic material that can lead to cancer. And you can inherit, obviously, from your mom or your father or dad. So somatic mutations occur in a person's DNA, but specifically in the soma, the tissues that aren't coming from the germ cell. And you don't inherit the mutations, or a person cannot inherit the mutations that occur in the tumor. And it happens sporadically, as I showed before, over time. We're exposed to different carcinogens, to UV factors that will cause cells to to be mutated. And then these mutations accumulate, different kinds of mutations, and that leads to cancer. So somatic is in the tumor specifically, and germline, something that we inherit. Okay. Again, the same thing. So at the top is an example of different tests that you can do. So foundation, and just not necessarily, I don't have any disclosures for this. But Foundation, HRD Mirus from Myriad, Caris, these are companies that do somatic testing. I think also Quest does it too. And this information can help you guide treatment. Germline also can sequencing, which happens again in the blood or the saliva, can also guide treatment. But a lot of it is in the context of risk reduction of your patient or of the family members. And examples of different companies, Invitae. Okay, Ambry's going out of business. No, not joke. So as I said, over time, there's an accumulation of mutations, and different tumors that arise in the body have a different kind of lifespan of the time it takes for a person to start acquiring these mutations and then for it to result in cancer. It's supposed to happen at a later age. That's why a lot of the work that we're doing now is trying to figure out why our population in the Caribbean and other Black populations are being diagnosed like 10 years, 20 years younger, okay? And the mutations. There are multiple types of mutations, but these are the most common kinds: single strand breaks, double strand breaks. Paulo, I think, presented about this from AstraZeneca. So DNA damage repair and response is triggered in particular by the double strand breaks, that's like BRCA1 and BRCA2. Mismatch repair, mismatch bases, and then intrastrand. And these mutations that result in tumorigenesis, or tumor being formed, happens in oncogenes. So these are genes that drive tumors. Tumor suppressors, these are genes that tell the cell when there is a mutation to stop. So if the stop isn't there, then it can lead to cells dividing and becoming a mass. And then, of course, genes that are responsible for repairing DNA. If the mutations occur in these genes, they can't function to repair the broken DNA, and then that allows the cell, again, to proliferate, to grow. So there are different kind of tests that are clinically relevant for thinking about the tumor, and you know lots of these. So we have, in terms of oncogenes, we have different tests like the FISH and immunohistochemistry, IHC. We can also do sequencing of the DNA to give us that information, whole genome sequencing, exome sequencing. This is usually what happens when you send assays for somatic testing, like Caris and Foundation. And then for the blood cancers, you have this BCR, ABL genetic testing. Okay. Let's see. This was maybe giving too much information here, but but you can do, the companies are doing lots of assays to be able to identify and tell you the types of mutations that are occurring in the tumor, so that you can determine, or they will suggest the type of drug that the tumor will respond to. Yeah. And you will see a lot of it is based on genetic sequencing of the tumor. So what happens when you take a tumor out of a patient, a biopsy, and you send it to the pathology then cuts this tissue, put it on a slide, and then you want to send it out. So what happens again with the companies? They extract DNA. I don't know how to. Oh. They extract DNA from no. They extract DNA from the tissue or blood that you collect. That goes into, that is then sequenced, and then we get results. And this is the results that helps us determine what type of mutations that exist with empirical data, knowing that, for example, DNA damage, like the PARP inhibitors would work in that patient population, or if they have MSI high, microcycline instability, where immunotherapy would be indicated for these individuals. Okay, so a little bit more about germline testing. So as I said at the beginning of my presentation, Myriad was the company that patented BRCA1 and BRCA2, so they drove the whole, that entire industry for a long time. Now it's beyond Myriad. And now we do panel tests. So the panel test is not just BRCA1 and BRCA2. Sometimes you might be asked to select. I would suggest you just do the whole panel. The panels can be 30 genes or even now up to 84 genes. Invitae has 100 and something genes. A lot of the genes that are on there are exploratory. We're just capturing, not we, the company's capturing data so that when they have tens of thousands, hundreds of thousands, they can start making associations with these rare, understudied genes. Genetic testing was done mostly by genetic counselors. Now you have clinic-based testing, so you can offer genetic testing to your patients. The companies also offer counselors so that you should not prohibit or inhibit yourself from offering genetic testing to your patients if you do not have a genetic counselor. The companies also provide that. If you don't feel comfortable in counseling the patient once they have actually a positive or negative result, especially in the context of a person with a strong family history, and they want to know what to do. And very importantly, germline testing requires consent. So you cannot just take the person's blood or saliva and not tell them what you're going to, well, you can't do that, or you can, but you shouldn't do that, because we are expected to return the results to the study participants so that or patient for you, so that they know their risk, and that, again, that they can maybe hopefully disclose that information to their family members. Okay, so somatic testing or tumor-only testing. Before, we were only looking at very specific genes. A long time ago, it was maybe even 10 genes, P53, some oncogenes like PI3 kinase, genes that we knew were strongly linked to developing cancers. Now we are doing whole exome sequencing. Some companies are still doing a panel of 800, or they will do whole exome sequencing, but they'll only report a few of the most important that they think is relevant to the disease. And Caris Foundation, they do about 800, and they also do whole exome sequencing in the background. Usually no consent is required for somatic testing. This is part of routine care. What is required is that you have the patient pay for it somehow, either through the insurance or self-pay, or if a company is providing the testing, that would likely indicate the utility of a drug. And yes, and mostly it's done in the setting of metastatic disease. Although now it's being done almost upfront in some instances, because there is like in ovarian cancer and endometrial cancer, because there is an immediate benefit to having PARP inhibitors. So before, we would just send the tumors. And then you would know that there are mutations in the tumor, but you would not be able to determine definitively if this mutation also exists in the germ, because there's immune cells in the tumor, there's fibroblasts, there's all other cells that are not tumor in the tumor, right? Because we're just like grinding up the tumor and sending it for sequencing. So now there's better practices where we are doing both normal sequencing and somatic testing. And that will give us a better call that these mutations that we see are only found in the tumor versus the patient's germline. And that's for something like BRCA1 and 2, and again, and other genes, PALB2. And that's really, again, important for you to be able to counsel your patient on whether or not they should either have some other screening done, some other type of risk reduction, and again, informing family members. Okay. So here, this is like why, so that's a disadvantage and an advantage. The companies now, let's see, Caris is doing this, Foundation One, Myriad is actually doing both germline testing independent of the tumor and then combining the two so they can give you information about both components. And so in the context of when we collect germline data to be able to better call mutations in the tumor, the patients are not necessarily consented. So there is a dilemma because I just told you don't do germline testing in the context of no consent. So we're encouraging, or clinicians have been encouraged to consent the patients for everything in the event that something is found in the germline. Okay. One of the caveats of doing germline testing in the context of patients with tumors, this is not gyne-related or solid tumor, is that you might find things in the germline that make you think that it's due to the cancer, but actually it's like the person walking around with a germline mutation. And that has happened in JAK2, which is part of the JAK-STAT pathway that is linked to heme cancers. And hence, depending on the type of tumor, you would want to use saliva versus blood. Just for example, you set up this system in your hospital and everybody starts referring their patients to you, that you have to think about like what is the germline that you're going to be providing to the company. Okay. Oh, okay. Yeah. So in terms of actionable, what that means is that if there is a mutation that we know for sure is leading to a change in the activity of the protein or the gene, and that actionable mutation that you will get a report of gives indication of whether this particular mutation that was found can be attributed to the a response to a standard of care therapy. So for example, for HER2 and endometrial cancer, right? Or BRCA, for example, in even endometrial cancer, ovarian cancer, breast cancer, and other diseases, cervical cancer, if you decide to do that. Okay. Oh, everything is kind of, yeah. So some additional considerations. When offering somatic testing to your patients, you have to think about whether it's worth doing this in the context of where they are in their treatment, especially when there might be a low yield in being able to treat them with whatever that's found. It sometimes is difficult to determine whether something is germline or somatic, and that's why you would want to communicate with a genetic counselor either through the company or even through your peers here. There's also another thing of finding incidental findings and wondering what to do about it. And of course, I don't talk about molecular tumor board, but that is where and do you all have a molecular tumor board, like the Cancer Society? No? But because you're going to start doing this more and more, it would be beneficial maybe to have a regional molecular tumor board so you can discuss the results and best practices of what you're finding in your study, in your patients. Okay. So there's another thing that is also happening now, circulating tumor DNA or cell-free tumor DNA, where you're getting your in individuals where you are unable to biopsy them safely, we know that tumor cells shed their DNA in the blood. And so we can use the plasma to capture that shed DNA. And so these are called liquid biopsies. It is important to take all of that into context. Again, because you're looking at blood, serum, or plasma, you're also going to capture normal things. So in particular, the JAK2 mutation, the BRCA mutations, and so you have to take everything into context. And then there's a thing called clonal hematopoiesis, which is just like cells in like blood cells that, and as we age in particular, have mutations, but that might not be actually leading to cancer, right? So just normal aging process. Okay. So there was this case report that I pulled from the web. I had another one on cervical cancer or vulvar cancer for BRCA mutation carrier, but then I didn't have enough time. But we can talk about this afterwards, and people can share their experiences. So there's this 73-year-old with metastatic breast cancer. And they have a strong family history of breast cancer. They were never offered germline testing. There was no easy biopsy, lesion to biopsy. And so they did a circulating cell-free DNA somatic/blood test. And then the results came back. Let me see. Yes. So they have a PIK3CA mutation. That's an oncogene. They have a mutation in BRCA1. And they also have a mutation that they found using just the serum plasma of P53. And the results come back saying that this person would benefit from a PARP inhibitor. So, of course, she had not done germline testing, so the reflex test is to do germline testing. This particular woman did not have a germline BRCA mutation, so likely it was due to clonal hematopoiesis, so just like cells obtaining mutations over time. And therefore, this particular patient would not benefit from PARP inhibitor because you did the germline testing and there was no germline mutation. And this particular patient eventually went on a PI3 kinase inhibitor. Okay. So in conclusion, tumor testing and germline testing can yield actionable variants. Great care is needed in interpreting the results, and because especially if your patient population does not have a lot of money to try different things, we have to be very careful in what we're offering them. Recognize caveats, in particular in knowing which tests to order for your patients, and importantly, keep up to date with the literature and clinical trials. It's a lot of work, but it's necessary if you're going to go into that space. And again, establishing a molecular tumor board can aid in decision making with interpreting results and having more folks think about what's going on. I think, yeah, that's it for me.
Thank you very much, Dr. Sophia George, once again. Our next presenter is Matthew Slumbrick. He's going to speak on navigating PARP inhibitors in ovarian cancer, part 1. Matthew.
All right, so the good news is that part 1 is going to be so fascinating that we're just going to go right into part 2 and put it all together, and then we're just going to postpone lunch by about 20 minutes. Everybody's excited about that. All right, so this is taking a little bit of a different approach from what we've discussed a little bit earlier today. This is a purely clinical discussion. We're going to talk about PARP inhibitors, when to use them, who to use them on, and those kinds of things. So these are my disclosures. So what we're going to do today is talk about the mechanism of PARP inhibitors, understand how they've kind of evolved in the ovarian cancer space specifically, and then how to identify appropriate patients for PARP inhibitors, because we've got several options from which to choose. And so I always show this to my medical students. This is clearly a group that I don't need to show this to, but this is what we're treating. Next slide. All right. So when we look at the evolution of treatments for ovarian cancer, we've been so far behind for such a long time. So back in the 70s, we had like alkylating agents and anthracyclines, and then platinum came into vogue, and then in the 1990s, we had the cisplatin carboplatin combination with paclitaxel, and so that was really great. And so that really revolutionized how we were treating patients, but we really didn't start evolving away from chemotherapy in either the primary or recurrent setting until after 2010. And that's when we started using things like bevacizumab, and then the PARP inhibitors kind of came into vogue. But really, compared to a lot of other disease sites, we've been so chemotherapy heavy for such a very long time that PARP inhibitors have really allowed us to kind of diversify what it is that we're doing with patients. And so this is kind of where we were at about 10 years ago. This is a little bit more of an updated slide in terms of the progress that we have made. So again, we kind of started with chemotherapy. We had this paradigm shift with bevacizumab, but that was in GOG 218. We were like, oh, this is so great. It's extending progression-free survival. Still no overall survival benefit in that study, though. And then later on in the 20-teens, we had PARP inhibitors come into play. And these were kind of evolved all the way out throughout this second decade. But we're starting to see how we can kind of use the interplay of PARP inhibitors with other kind of targeted therapies, but also where can we be a little bit nuanced and when we use the PARP and who we should use the PARP on. And so that's kind of what we're at now. So what I'm going to talk today about is a lot of studies that involve PARP inhibitors, kind of how we have come to where we are and where we are trying to go right now. So Dr. George could probably spend 2 hours on this slide alone, but I'm a clinician, so we're going to go really quick on this. So this is the Fanconi anemia pathway. We've talked a lot about a number of mutations, which you can see here in the HR factors slide, section of the slide right here. So there are a number of proteins that these genes code for that all form what we refer to as the BRCA complex, and this is what is required for double-stranded DNA repair. So when we have mutations in one or perhaps more than one of these things, we start to get interruptions in how the cells can fix their own DNA when a mistake has been made. And the PARP inhibitors really kind of focus in this area here, which are referred to on this slide as HR or homologous recombination factors. So any mutation in the homologous recombination pathway leads to homologous recombination deficiency. This can manifest, as others have discussed earlier today, in a number of different ways. You can have a germline BRCA mutation, which is where PARP inhibitors were initially studied. You can have germline non-BRCA mutations in this pathway, so that's things like the RAD51C and D BRIP1. You can have somatic or tumor-related BRCA mutations, so that's, again, just within the cell in the germline. And then you can get sporadic non-BRCA mutations in this pathway. So that's going to be a somatic PALB2, RAD51C, and D, ATM mutation, et cetera. It's really important, and others have hit on this today, that we test people for homologous recombination deficiency. Half the patients are going to have it. And when I show you the data a little bit later on, you'll very convincingly see that this new drug or class of drugs has such a profound impact on patient survival that identifying these patients right from the onset is really important to translate into improved outcomes. Sophia showed this a little bit earlier. This is very relevant for our population here in South Florida, specifically in the context of our Bahamian patients who we're treating. But as Sophia demonstrated, there are a number of different countries throughout the Caribbean where we see elevated percentages of patients who've got BRCA mutations or other mutations. And so really kind of identifying patients who've got hereditary breast and ovarian cancer syndrome who are going to benefit from PARP inhibition is really important. Okay, so generally speaking, PARP inhibition is important for, or PARP is used for double-stranded DNA repair. So basically what happens is you get a single-stranded break and PARP kind of binds to that. And then the way that it fixes the DNA is it kind of transition it into a double-strand break and then fixes the double-strand break. If you've got the PARP inhibitor kind of sitting on that single-strand break, it inhibits the base excision repair. But then what happens if you've got subsequent homologous recombination deficiency is that those cancer cells cannot fix their own DNA, and so the cell undergoes apoptosis. And so we talk about this kind of synthetic lethality. If you already have this abnormality in the cell's ability to repair double-stranded breaks, if you inhibit its ability to repair single-stranded breaks, then now there are two ways that it can't fix its DNA and it doesn't know what else to do, and so it basically just kills itself. And so we're basically leveraging one of the inherent deficiencies by blocking its escape pathway. So one of the first studies on olaparib was monotherapy in multiple cancers that had germline BRCA1 and 2 mutations. And so you'll kind of see as we go through that there's been kind of an expansion of patient participation, but this all started with the germline BRCA patients. And so this included ovarian cancer in patients who had platinum-resistant disease. We had breast cancer who'd had greater or equal to 3 lines for metastatic disease, pancreatic cancer if they'd had prior gemcitabine, and then prostate cancer with 1 prior systemic therapy and progression on hormonal therapy. And the primary endpoint in this early study was tumor response rate. And what you can see in the ovarian cancer slide here is that you actually had in this heavily pretreated population 6 patients had a complete response, 54 partial responses, and 78 patients with stable disease. And so when you look at the clinical benefit rate, we are talking 60%. And these are people who at this point in their disease process are going to respond to practically nothing. So this is a real game changer. And so this has driven a lot more of our studies here. And so back in 2018, when a lot of the kind of newer studies were coming out with olaparib, niraparib, and rucaparib, pretty much everybody could get a PARP. Frontline PARP. First platinum-sensitive recurrence PARP. Oh, you've had 4 prior lines of treatment, PARP. Everybody got a PARP. So it was just like a giant party, which was really great. But no. We have learned a lot since then, and we've got a lot more nuance about who we're including on some of these trials and really kind of understanding the importance of the endpoints. So in the last several years, we'll be sitting at our desk, we open our email, and we get these things called Dear Healthcare Provider. If you see something that says Dear Healthcare Provider in the subject line, you know something bad is going to be in the subject text. So basically what they did is put pause on most of the indications for PARP inhibition, and this was driven by the fact that overall survival endpoints seem to be deleteriously impacted by PARP inhibition. Now, if you read the papers in a very granular kind of way, and this has been one of the arguments that we've had in discussions with the FDA, is that a lot of the confidence intervals cross 1. And so you're like, okay, so I can see where there may be a trend toward worsening, but statistically that's not true. But for the FDA, that was sufficient enough for them. And so they pulled indications for many of the things. And so this is the current indication for us here in the US for PARP inhibition. We're going to go through the studies that kind of drive this, but more or less, people can use olaparib for their first remission. So that means they've had their carbotaxol and then they're getting their maintenance. And then if they have a recurrence with platinum-sensitive disease, they can use it again. Olaparib combined with bevacizumab can be used in patients after they've had their primary therapy, if they've got a germline or somatic BRCA mutation, but also if they're HRD positive. For niraparib, they need to be germline or somatic BRCA mutated or HRD. There used to be an indication for wild type, not anymore. So this was one of the drugs where everybody could get it and not anymore. So if you've got a wild type or HRP, homologous recombination proficient patient, they can't get anything anymore. There's also been a change in who can get it for their first recurrence. And essentially, if you're germline, BRCA mutated, and you've had a platinum sensitive recurrence, you can get niraparib. Otherwise, sorry, you can't. Rucaparib, which was kind of like one of the top 3 when things started coming out. It's really not been utilized all that much. There's some issues with liver function elevation and things like that. But essentially, it's the same indications for, or as it is for niraparib, with the exception that somatic BRCA mutation in the setting of first platinum sensitive recurrence is allowed. So how did we get here? So I put this in here for historical context because you notice it wasn't in the chart before. So veliparib was a very weak kind of PARP inhibitor, and so there's all this excitement about what if we give a PARP inhibitor with their primary chemo and then we use it for maintenance, right? Like more is better. And when you see here, this is the veliparib throughout versus the control, and in the Kaplan-Meier curve, you're like, oh great, that's a separation, perfect. And when they break it down by BRCA mutation versus homologous recombination deficiency, we see Kaplan-Meier curves that are kind of spacing out. You're going to see this pattern over and over again with all of the PARP inhibitors. But when we looked at the data that came out with the other PARP inhibitors, if you give veliparib with chemo, you enhance the thrombocytopenia, so they had a much greater risk of cytopenias and nausea, but the progression-free survival benefit was the same as if you were to give all of the other PARP inhibitors, but just for maintenance. And so the argument has become, why are we going to do PARP inhibition plus chemo when we're enhancing toxicity and it's not translating into a survival benefit for the patients? So veliparib, while there may be indications for other diseases, like breast cancer still uses this, but there's not really a role for it in the GYN cancers, even though there was some degree of response. So really, we're not looking at PARP inhibition with chemo, we're looking for it after chemotherapy. So the SOLO-1 trial utilized olaparib in a phase 3 setting. These are patients who had stage 3 or 4 high-grade serous or endometrioid ovarian cancer, those two histologies only. Primary peritoneal fallopian tube was included. They needed to have germline or somatic BRCA mutation. HRD and HRP status was not evaluated in SOLO-1, which is why it's not an indication for olaparib as a single agent. Then they needed to have had their surgery, complete or partial response, and that's kind of a similar setup to what we're going to see with a lot of these other studies. They either got olaparib 300 milligrams BID or placebo. The treatment schema was 2 years, and they were randomized 2 to 1. So 2 people got olaparib and 1 got placebo. Primary endpoint was progression-free survival. So we were very, very excited about this because I guess this didn't show up. All right, so anyway, the Kaplan-Meier curves really separate out. So what happens at the 5-year mark is that you actually start to see continuation of response in the patients who got PARP inhibition. And at 5 years, they still have 50% of patients who had not had a recurrence. And so in these germline BRCA patients, PARP inhibition post-chemotherapy treatment may actually be curative. So there's going to be people who had stage 4 disease who 10 years ago we'd say, sorry, like this is going to be terminal for you, and now we can actually cure them. They provided some updated data on SOLO-1. This was presented at ESMO in 2022. We still see a very robust improvement in the overall survival. And you can see the hazard ratio, it's a little bit small here, 0.55. So we have a 45% reduction in mortality in patients who got olaparib on this study. So the next one is niraparib. This is the PRIMA study. So with niraparib, the setup was very, very similar. So in the niraparib patients, they were either randomized to niraparib 300 milligrams orally daily or to placebo. These patients all had completed their primary chemotherapy and were getting their consolidative therapy. The difference with the PRIMA study is that they started to implement and include homologous recombination deficiency as a biomarker. And so they did their analyses kind of in that way. A thing that's really important here, again, the histologies that were included in the PRIMA study were like the SOLO-1 study, so it's serous, high-grade serous, and high-grade endometrioid only. And so when these data were reported, they kind of reported out the difference in survival. And on the left, you can see BRCA wild type. In the middle, you can see BRCA wild type and homologous recombination deficient. And then on the right, you can see HRP. So these are going to be people who don't have a BRCA mutation, who don't have homologous recombination deficiency. So that's about as normal unmutated ovarian cancer as you can get. So this is really not surprising. Niraparib did great in patients who had a BRCA wild type, or sorry, a BRCA mutation. People who had homologous recombination deficiency, but in those who didn't, not so great. So kind of the take-home message of this was that if you've got a BRCA germline mutation, you've got a BRCA somatic mutation, or you've got a BRCA or non-BRCA homologous recombination deficient tumor, they're all going to respond to PARP inhibition. It's really just those people who've got HRP disease and are not going to respond. These are some of the updated data from 2022. We continue to see that there's improved median progression-free survival. All of these are statistically significant. And then we've got reductions in estimated probability of recurrence or death. Now, one of the things that we learned significantly about niraparib is that dosing is very dependent on two features. One is weight and the other is platelets. 70% of the people in the PRIMA study required a dose modification purely because they had such significant cytopenias. One of the things that's really unique about niraparib is that in the first 4 weeks on niraparib, we can start to see these profound issues with thrombocytopenia. And it's not a real linear kind of relationship. It can just kind of fall off. And so they were seeing marked substantial cytopenias in the first 4 weeks. So what they have done, this was kind of a follow-up study, and there's another kind of prospective study that has confirmed this, is that if your weight was less than 77 kilos and your platelets were 150, if you started with a dose modification, there was markedly less thrombocytopenia, anemia, and neutropenia. So that's the group on the right-hand side. If you see on the left-hand side, people who were started at the 300 milligram dose, 50% of them had thrombocytopenia. And so the caveat for niraparib is when you're deciding who gets their starting dose, look at their platelets at the end of chemo and look at their weight. So this is the PRIME study, which is looking at niraparib with individualized dosing. This was a prospective study, so the enrollment criteria were exactly the same as the initial PRIMA study. They did stratification based on germline BRCA mutations, HRD status, again, 2-to-1 kind of randomization, and then the individualized starting dose was utilized using weight and platelets. And essentially what they found was that all of these things favor niraparib. So the outcome is the same in the PRIMA study, but there is less toxicity. So take-home point, if you're going to use niraparib, weights and plates to make the initial dosing calculation. Then if we look at rucaparib, that's the Athena mono study. So this was a randomized phase 3 to evaluate rucaparib as maintenance in these patients. Things that are important here is all epithelial tumors were allowed, including clear cell and mixed. And so this is different from the other two because, remember, the other ones were just high-grade serous and high-grade endometrioid. Here, pretty much everybody was allowed. So that's a really important thing because this is a drug where if you've got somebody who's got a more rare histology, you may be able to utilize it if they meet criteria. So with the Athena mono study, rucaparib, this was also like a 2-to-1 kind of randomization, and then these patients were followed. They did look at not only germline, but somatic and HRD positivity. And much like what we've seen for the other patients, we see a difference if they're germline mutated, we see a difference if they are somatic mutated, and we see a difference if they are HRD. So again, kind of expanded access here with that. These are the toxicities, things to kind of note here. My apologies, is that there is a significant increase in AST and ALT combined or relative to the other studies. And so when somebody's initiated on rucaparib, you have to kind of anticipate that you're going to see, it's often a transient elevation in the liver function test. It doesn't really have a functional issue. The bilirubin is not elevated, so this is kind of like a mild hepatitis that often spontaneously resolves, but it's something that you need to keep an eye on. The cytopenias were less than that seen in niraparib. There is a disparity in these studies, and so when we're looking at these are pretty much all European patients. So in the PRIMA study, that's the niraparib study, only 1.6% of the women were Black. In Solo 1, they didn't even report on patient demographics, so you don't even know who the patients were on this study. And the Athena mono study had no Black and no Hispanic patients. So, this is a very important consideration when we're looking at giving these medications in diverse populations of women. We know that there are variations in cytochrome P450 enzymes. Drug metabolism is going to differ. And so the clinical trial that Dr. George had mentioned earlier, which will be opening in Nigeria and Bahamas, is really to kind of address this issue and implement standard of care PARP inhibition, but really kind of track pharmacokinetics, outcomes, assess safety, because I think that would provide so much more robust data to say, yes, these drugs are safe in a population, or no, they are not safe, or there needs to be modification in initial dosing. Okay, so let's touch on PARP inhibitor and bevacizumab. So, when Bev came out, it was like the golden child. Like everybody was going to get cured with Bev. Everybody's going to live forever on Bev. And that's not been what has happened. But now we've got great outcomes for olaparib. We had great outcomes for bevacizumab. So why don't we just put everything together, because that's kind of what we do, right? So this is the PAOLA study. So this is FIGO stage 2 to 3 high-grade serous or endometrioid. So this is utilizing olaparib. So the study schema is very similar to the SOLO-1 study, with the exception that they did look at homologous recombination deficiency in this study, which was a departure from the SOLO-1, because they wanted to expand access and indications. So this is olaparib 300 BID for 2 years plus Bev, or placebo plus Bev. And then PFS is the outcome for this. And this is really exciting because you can see olaparib plus Bev versus placebo plus Bev does better in like every single one of these sub-analyses. One of the big criticisms of this study is, where is the PARP inhibitor plus placebo arm, right? Because how do we know these differences aren't being driven by olaparib and not just the bevacizumab? And so there's been a lot of criticism about this study because the trial design didn't include that really third important arm that's going to allow us to determine if the addition of bevacizumab with the PARP inhibitor is actually really meaningful. Because clearly, if we're doing placebo plus Bev, like, we've had that data for more than 10 years. Like, we know kind of what that's going to be. So there may be some indications for this for some people if you want to specifically use olaparib in a high stage person who's got homologous recombination deficiency. But I think when we're implementing this particular study and these data into practice, we're a little bit less excited about it. So these are the updated data on olaparib plus Bev and placebo plus Bev. And again, you can see it's all really good, but at the 5-year PFS rate at 46%, if you look at the SOLO-1 data, it's not that different. And so for us, if you've got somebody who started on Bev because they had like liver mets or something like that, and you want to include a PARP inhibitor, continuing the Bev and adding the PARP is usually where we would use these data, but it's really not that common where we're going to initiate this at the end of chemo primarily. And then again, more data to show that if you're homologous recombination deficient or homologous recombination proficient, so basically the cells can fix their own double-strand DNA breaks, like, these things don't work. And so not really an indication for those people. So data to directly assess the utility of Bev in combination with PARP inhibitor maintenance is pending. So, one company did it, so that all the companies have to do it to show that their drug is really good too. So the Nirvana study is looking at niraparib and Bev. The AGO over 28 is looking at niraparib versus niraparib plus Bev, which is probably a better study for the reasons that I just mentioned a couple minutes ago. So is it the PARP inhibitor or is it the VEGF inhibitor where we're starting to see the importance? And then similarly with MITO 25, they've got a similar schema. So we'll kind of see if bevacizumab is something that we kind of loop into our primary maintenance therapy setting. Okay, so let's transition. So now we're going to talk about patients who've had their first platinum-sensitive recurrence, and then what can we do for maintenance in these patients? So SOLO-2 was a phase 3 study looking at olaparib in platinum-sensitive BRCA-mutated recurrent ovarian cancer. So these are patients who had BRCA germline mutations greater than or equal to 2 prior lines of platinum with a complete or prior or partial response. Again, 2-to-1, 300 BID versus placebo. PFS is the outcome. This is essentially the exact same as the SOLO-1 study. And we can see here that olaparib far outpaces placebo. So even if somebody's had a platinum-sensitive recurrence and they are a germline BRCA-mutated patient, we're still going to see some benefit. And here, this has a hazard ratio of 0.3, so 70% reduction in progression-free survival. Now, SOLO-2 was not that far after SOLO-1, and so PARP inhibitor after PARP inhibitor, we have less data on. I think most of us are still doing that for the germline BRCA mutated patients, but I think as time goes on, we'll be able to see a little bit more longitudinal effects in terms of toxicity and secondary malignancies, as well as survival benefit when you do PARP following PARP. The NOVA study uses niraparib. This is also platinum-sensitive recurrent ovarian cancer. These are germline BRCA mutated versus non-germline BRCA mutated, and it's niraparib versus placebo. Again, this is a very similar study schema as the PRIMA study, And again, not surprisingly, niraparib does better in the germline BRCA mutated, the non-germline BRCA mutated, and then the HRD positive. And so again, for these patients, we may have an opportunity. Ariel 3 looked at rucaparib in platinum-sensitive recurrent ovarian cancer. So these were patients who had high-grade serous or endometrioid, so this was a little bit different in the initial rucaparib upfront study. This is, again, the same, greater than or equal to 2 prior platinum regimens, sensitive to their last platinum with response. Rucaparib 600 BID versus placebo, PFS is the endpoint. And again, not surprisingly, patients who had a BRCA mutation or homologous recombination deficiency did better if they got PARP inhibitor versus placebo. So one of the things that we talk about often is myelodysplastic syndrome. And this is a very significant diagnosis because once your ovarian cancer patient gets MDS, forget about trying to treat her for ovarian cancer. This is a lethal diagnosis, and I'm sure my colleagues here can share their experience, but in my experience, once your patient gets MDS, like the rate of how quickly it accelerates and how quickly they die, frankly, is fast. It's important to counsel your patients because when you read the package insert, it does say myelodysplastic syndrome. And this is something that patients will ask about because they get really anxious about getting treatment for one cancer that may cause another cancer. So this is when counseling is really important for them. Overall, it's really not that crazy, right? So in the SOLO-1 study, that's with the olaparib, it's 1.5%. For the PRIMA study with niraparib, it's 0.2%. For the PALO, 1%. For the ATHENA mono, it's 0.5%. So in patients who are getting their upfront chemo and then their upfront PARP inhibitor, the risk is very, very small. When we start to see the risk go up is actually in patients who are heavily pretreated. And you can see the Ariel 3 that's fifth from the bottom, or fourth from the bottom. If they were on a PARP inhibitor for greater than 24 months, then they had already gotten treated now twice with carbotaxol. Their risk of MDS was 11.4%. And so we see MDS in patients who've gotten more prior chemotherapy because there's been more DNA damage that has occurred as a result of their chemo treatments. We also see MDS more often in patients who have gotten treated previously for breast cancer and then have a second cancer, and that's because they've been treated with their chemo for breast cancer, which often includes an anthracycline. And so in those patients, not that you're going to offer anything different, but you just want to have a higher threshold to kind of work up their anemia. It's very uncommon for this to be something where they're fine 1 week and then the next week they're in fulminant MDS. You're going to see kind of trends in all of their cell lines. So what I would say is that if you've got a patient, and this is even independent of whether or not they've had PARP inhibition, if you start to see these trends in their counts, downtrends, maybe you're transfusing them a little bit more often, these are the people to get evaluated by hematology. There are a number of kind of genetic and inherited hematologic issues that I've actually identified or have been identified in my patients. And this can be very informative working with the hematologist about what chemos you can more safely give versus not safely give. And I've had patients where they have told me, do not give her any more carboplatin because she's going to get MDS if you do. And so in the interest of allowing your patient to stay on treatment, just have kind of an appreciation for the risk of MDS in these folks. So this is just to kind of like come back to what we had talked about before. So all of the studies that we had talked previously are kind of informing this right now. So the good news is in somebody who has a BRCA mutated tumor, or their germline BRCA mutated, or they've got HRD, which is half of the patients, they're going to benefit from PARP inhibition. The onus on us now is what do we do for these patients who don't have any of that, the other half? And for right now, there's not a whole lot of good stuff. So we either put them on just regular maintenance, we put them on bevacizumab, maybe. There's some weak phase 2 data about letrozole for consolidation, and letrozole is cheap. They don't need an infusion. It's not going to affect their counts. So if you've got a patient who wants that, that's not a bad idea. But the landscape is definitely changing. So I want to conclude just briefly with a couple patient cases to kind of put this together. So patient 1 is a 45-year-old who's got a germline BRCA2 mutation. She has stage 3C high-grade serous carcinoma of the ovary. She undergoes primary optimal cytoreduction, completes 6 cycles of carboplatin and Taxol, and had a complete biochemical and imaging response. So this is actually what we would expect for this patient when she presents. So what are her options for maintenance? Olaparib, olaparib plus bev, niraparib, and rucaparib. So for her, she is dealer's choice. Whatever you feel like, whatever she wants to talk about, that's cool. Things that are important, I think, for these patients is the length of PARP inhibition maintenance. So the SOLO-1 study with olaparib was 2 years. The PRIMA study with niraparib, for example, was 3 years. It's very common when you get to the end of that time that you see a substantial dichotomy. Patients are either like, get me off of this drug, or I am never coming off of this drug. I would say that most patients lean to, don't ever take me off of this medication. So I think it's an important thing to discuss with them, particularly in the context of MDS, because we don't have data on people who are on PARP inhibition for years and years and years and years. That's probably coming, but it's something to counsel them about. And when I get to this inflection point with my patients, I do talk with them about that risk. If they choose to stay on because they feel fine, they've had no issues, I mean, I'm fine with that. There's patient autonomy, and I don't think we're hurting them by keeping them on. But again, something important to keep in mind. Patient number 2, she's BRCA wild type, but she's HRD positive. She's got stage 3C, grade 3, endometrioid adenocarcinoma of the ovary. She got neoadjuvant chemo with platinum and taxane. Optimal cytoreduction. She completes adjuvant therapy. She had a complete response. What is her option for maintenance? So her options are pretty much everything but olaparib as a single agent. So remember, the SOLO-1 study did not allow patients who did not have germline BRCA mutations. They had to be germline for SOLO-1. Now, one of the things about the PAOLA study, which would allow olaparib plus bev, is that the way that study was written is they needed 2 cycles of bev to be able to qualify. And so again, this kind of underscores, if somebody's just getting carbotaxol by themselves, you're not gonna like give them bev if you didn't give them bev beforehand. So this lady, in theory, if we had added bevacizumab, I think could have been okay for this, but my preference for her would actually be niraparib or rucaparib. Okay, so 55-year-old with 3A clear cell carcinoma, tumor is HRD positive. She undergoes primary cytoreduction, gets 6 cycles of platinum taxane, no bev. She has a complete response. What are her options? Her only option is rucaparib, because remember, the other 2, you had to be high-grade serous or high-grade endometrioid. Rucaparib is the only one that allowed clear cell and mixed histologies. So again, if you've got these more rare ovarian cancer histologies, you may be kind of pigeonholed into which one you're able to use. You can use olaparib and bev maybe, if you are bending the rules just a little bit. I say that because there's benefit. If patient 4, BRCA wild type, HRD negative patient. So this lady is not really got good genomics working on her side. High-grade serous carcinoma, she had carboplatin and Taxol. She placed on observation. She got recurrence 12 months after treatment completion. She's rechallenged with the platinum doublet and bev with a complete response. What are her options for maintenance? Bev or clinical trial. So she doesn't meet any of the criteria for PARP inhibition. You can continue the bevacizumab, or if there's a clinical trial for maintenance, that would be an option for her. So I went kind of fast, so we have lots of time for lunch now, actually. All right, that's all I got. Thank you so much.
We're looking at endometrial cancer in our Jamaican population. And what we found is that we had predominantly, as your study showed, predominantly more high grade endometrial in our Jamaican population. And I'm just putting it out to the floor. Is it time that we either start doing molecular testing or ask our general gynecologist to refer all these endometrial cancers? Because particularly when you come to things like the carcinosarcoma, when they're doing a lot of Pepel sampling, you tend to get the biphasic type where they get either endometrioid, and when this histology it come back as a carcinosarcoma, and the patient is inadequately staged, and then by the time they get around to you, the disease process is more advanced, and you're just going down Mulberry Hill. So I don't know what the people around here think.
Thanks.
So we're actually seeing this here too. We also did a retrospective study of the patients who got treated here at UM and similarly found that 72%, I think, of our Caribbean-born Black patients had high-grade endometrial cancer. There is a very well-characterized marked increased risk for high-grade histologies among women of African ancestry. The complexity is significant in terms of understanding why that is. And I think we would be naive to say it's genetically driven or it's environmentally driven, because I think in reality, there's substantial interplay. And I think some of the things that Alyssa touched on in her paper is that the experience of life, exposures, and particularly in our immigrant population, what's the experience of immigration? What are the stresses? We know that there's a degree of chronic inflammation that goes into cancer etiology. How is the stress that somebody born in Jamaica who came to the US versus somebody born in the US and raised in the US, like how does that differ? People's dietary habits change. They vary. People's family structure changes. People's living situations change. All of these things really kind of go into cancer risk. And the questions that you are asking are the exact same questions that we're asking here. We recently were awarded some funding from the Department of Defense to answer this question. So we will be looking at germline and somatic mutations in African descent populations from a retrospective perspective and from a prospective perspective. This will allow us to do a couple of things. One, what is the genetic risk, the germline genetic risk for these high-grade endometrial cancers? Because there's some data on Lynch syndrome, but it's sparse. And then there are high-level retrospective data, like population-based data, as Dr. George had suggested, that there may be an increased risk, a marked increased risk for serous carcinoma associated with the BRCA1 mutation. In those population studies, though, they were all done in Canada and the UK and the US. And so, again, like representation and research matters. And so it's hard for us to extrapolate anything specifically for our Caribbean population. So along with getting germline and somatic mutation, Dr. Camille Reagan, who's up at Fox Chase, epidemiologist, she's actually Jamaican. She leads the African Caribbean Cancer Consortium, which I would encourage everybody to evaluate and consider membership, has like a 70-page epidemiologic questionnaire. And in this questionnaire, it's things like, what kind of meat do you eat? But not just that, how do you prepare your meat? Where do you get your water? What kind of work do you do? Because all of these things translate into exposure. Those exposures induce epigenetic modifications, the DNA, which can be translatable into cancer risk. So we're hoping that by taking a high-level view, even in this relatively small pilot study, we'll get some preliminary data. But what's really going to be needed is a large cohort of women to be able to really kind of parse out some of the subtleties about this. I think that these patients should absolutely all go see the GYN oncologist if it's logistically feasible. And I say that because we see exactly what you're seeing as well. Patients come to us, there's now treatment delay introduced because they weren't staged appropriately, and these tumors are so aggressive, by the time you get them, they've got metastatic disease, and you're like, well, I guess we're going to treat you with palliative chemo now, you know?
Any other questions? Any other comments? Yeah. Riley?
This is a political one, Matthew. We have a mutual patient who was probably a stage 3C, who had surgery, who had chemotherapy, and who's on olaparib maintenance for over 3 years and won't stop. What do we tell her? We certainly have risk reduced her. She's had a mastectomy. So you and I were concerned, boy, if something else comes, we've already thrown everything at her through ovary, and she would not give up the olaparib.
So for that patient specifically, if I remember correctly, she'd had a substantial dose reduction in the olaparib. So, and I think that she was even on like when they're doing the 50 milligram tablets. I mean, like not even the current dosing formulation. But again, I think the important point of this is that if they've had no prior chemo for either their ovarian cancer or any other malignancy, then the risk is relatively low. And so for those people, I do counsel them. I don't sway them one way or the other. It's hard sometimes because more so with olaparib, but you can see with some of the other PARP inhibitors too, you're going to see like MCV, the RDW, and when patients get their labs and then they see that there's an abnormality, even if it's not clinically meaningful for us and we know it's a side effect of treatment, there's this kind of freak out. But also keep an eye on those things because even those subtle lab abnormalities can sometimes suggest that something's happening. If it's, for her, like her risk is probably at 1.5%, I think it's fine. If she'd been heavily pre-treated for her breasts, then I think we'd have to have a conversation. But this is definitely like a patient autonomy thing for me. Sure.
Thank you. For a patient who BRCA mutation, germline BRCA mutation, is on olaparib, discontinued because of she's gotten to a 2-year mark, and then started having elevations in CA125, not significant, right? Still within normal limits. Had a PET CT that showed that she had some recurrent disease, small lymph nodes. Now going back on chemotherapy, do you put her back now on maintenance PARP inhibitor? Because you can't really say that she didn't progress on the PARP because she just discontinued the PARP maybe 3 months only because she had gotten to her 2-year mark. And so she stopped the PARP at that time.
So I think there's a number of things you could do with that patient. More than likely, she's going to have some degree of response to PARP inhibitor if you treat her again. I would not use the same PARP inhibitor. We know that some PARP inhibitors like niraparib is a stronger PARP trapper than olaparib is. So if she was on olaparib and there's access to niraparib, I would consider that. In the patients with recurrent disease, these are also the ones where I would have a much lower threshold if Avastin is part of their treatment plan to use the combination of Bev and PARP inhibition. Those data are clearly forthcoming, but I think there's a much stronger push in the recurrent setting to use Bev. She may not get a ton of benefit. I've done PARP after PARP, and invariably, it's going to be less. One of the things as a sign is there are retrospective evaluations of the utility of CA125 in the setting of PARP inhibition, and it may not actually be the best indicator of disease recurrence. And there are some who would argue that you should scan people routinely when they're on PARP inhibitor. I don't do that in my practice. I do it as if we would have them on routine surveillance, follow their CA125 and their symptomatology. But CA125 in the setting of maintenance with PARP, there's some controversy about that. Does that answer your question? Okay.
Okay, if there are no more questions or no more further statements by anyone, we congratulate the speakers in the second session of this afternoon.